Welcome to this rapid-fire clinical explainer. We're jumping right into our virtual clinical rounds, focusing on spinal and systemic pathologies. Get ready for a continuous flow of high-yield cases. Section 1, lumbar red flags. Notice those warm, urgent colors on screen. We are actively hunting for critical warning signs in the lower back here. Let's go. Here's our first diagnostic dilemma. A 40-year-old female presents to the spine clinic complaining of back pain. Now, you gotta ask yourself, which of the following is a true red flag sign in this specific context? Is it A, age 30 to 40, B, painful urinary retention, C, minor trauma, D, numbness in the buttock, or E, none of the above? The correct answer is D. Okay, let's dive into this. Numbness in the buttocks or perineal region is what we call saddle anesthesia. It's a huge red flag because it indicates compression of the sacral nerve roots right within the cauda equina. This signals serious spinal pathology that literally requires immediate diagnostic imaging so we can prevent permanent neurological deficits. So let's lock in some key exam pearls here. First off, saddle anesthesia is your classic warning sign for cauda equina compression. Second, and this is absolutely crucial, the characteristic urological red flag is painless urinary retention. Not painful, painless, because the bladder is completely denervated. Finally, keep those strict age cutoffs in mind. Back pain presenting in patients younger than 20 or older than 50, that is an absolute demographic red flag. Moving right along to our next patient, we have a 30-year-old male presenting post-trauma with progressive bilateral lower limb weakness, decreased anal tone, and perianal anesthesia. With neurological deficits this severe, what investigation are you going to carry out? Would you order A, an ultrasound, B, a CT scan, C, a CT myelogram, D, an MRI, or E, nerve conduction studies? The answer is D, MRI. This specific clinical constellation absolutely confirms cauda equina syndrome. An urgent MRI is the gold standard modality here. And this brilliantly illustrates exactly how we visualize the soft tissue architecture to definitively demonstrate central canal occlusion. Now, you might be wondering, why the rush? Well, the magic number is 24 hours. Cauda equina syndrome is a true neurosurgical emergency, most frequently caused by a massive central lumbar disc protrusion. If decompression surgery is performed within a strict 24-hour window of bowel or bladder impairment, it yields significantly superior functional recovery outcomes. Every hour counts. Let's shift gears to a classic mechanical presentation. A 60-year-old man was lifting weights and suddenly felt dull lower back pain radiating all the way down to his right leg. What is the probable diagnosis based on this history of acute axial loading? The choices are A, lumbar disc prolapse, B, cervical spondylolysis, C, vertebral fracture, D, cervical radiculopathy, or E, cervical myelopathy. Yep, it's A, lumbar disc prolapse. That sudden pain radiating down the leg, that is textbook sciatica. It's usually caused by a symptomatic disc herniation compressing an adjacent spinal nerve root, and you'll most frequently see this occurring right at the L4/L5 or L5/S1 levels. So, how do we handle this? Initial management for simple, non-progressive sciatica isn't immediate surgery. Actually, scratch that. It's almost never surgery right away. From weeks 1 through 12, conservative care with neuropathic analgesic is the absolute standard. We strictly reserve surgical interventions like a microdiscectomy for post-12 weeks, and only if the patient has completely failed that conservative care. Section 2, cervical spine pathologies. We're moving right up the spine to the neck now, keeping this momentum going. Check out this complex mixed neurology case. A 60-year-old patient complains of pain in the upper limb. On examination, you see wasting of the hand muscles, but you also notice upper motor neuron signs in the lower limbs. How on earth do we synthesize these conflicting physical findings into a probable diagnosis? Is it A, spondylolisthesis, B, spondylolysis, C, disc prolapse, D, cervical myelopathy, or E, anterior spinal artery occlusion? The answer is D, cervical myelopathy. So the crucial point is that when degenerative spinal changes actually compress the cervical cord, it manifests as this highly specific, mixed neurological picture. Let's visually break this down so it sticks. On one side, we have lower motor neuron, or LMN signs, exactly at the level of the lesion. This explains the wasting of the intrinsic hand muscles, typically at that C7 to T1 level. But on the other side, we see upper motor neuron, or UMN signs, below the lesion. We're talking hyperreflexia, clonus, and a positive Babinski sign in the lower limbs. Why? Because of the downstream cortical spinal tract compression.
All right, moving to a purely anatomical question. Statistically speaking, which are the most commonly involved nerve roots in cervical radiculopathy? Your options are A, C4, C4, B, C5, C6, C, C6, C7, D, C7, T1, or E, T1, T2. The correct answer is C. Cervical radiculopathy statistically compromises the C7 nerve root the absolute most frequently, which arises right from that C6, C7 disc level, and that's closely followed by the C6 nerve root. Let's map this out to localize the exact herniation level. If you have C7 root compression, it manifests as triceps reflex depression, weakness in wrist and elbow extension, and paresthesias tracking straight into the index and middle fingers. Contrast that with C6 root compression. There you're looking at biceps reflex depression, weakness in biceps flexion, and numbness radiating very specifically to the thumb. Knowing these exact reflex and sensory maps, it's a real game changer for diagnostics. Section 3, systemic and sacral tumors. Let's round out this clinical shift by focusing on some rare tumors and genetic conditions. Here we have a young patient presenting with multiple swellings over the body. On examination, you notice brown stains on the skin. And here's the kicker. The patient tells you his father and brother suffer from the exact same skin lesions. What's the most probable diagnosis given this classic triad of physical signs and a really strong autosomal dominant family history?
The options are A, neurofibromatosis type 1, B, neurofibromatosis type 2, C, Derkham's disease, D, Peutz-Jeghers disease, or E, Addison's disease. The answer is A, neurofibromatosis type 1, or NF1. Now, what's really interesting about this slide is how perfectly this clinical picture aligns with the strict diagnostic criteria for von Recklinghausen disease. We have to clearly differentiate between type 1 and type 2 here, because it's a heavily tested and clinically vital distinction. NF1 requires features like 6 or more café au lait spots, Lisch nodules, or axillary freckling. And those neurofibromas actually carry a distinct risk of transforming into malignant peripheral nerve sheath tumors. On the flip side, NF2 is dominated by central lesions. It classically presents with bilateral acoustic neuromas, meningiomas, or juvenile cataracts, and it typically lacks those widespread cutaneous swellings we saw in the first patient. All right, moving to our final question, in which of the following areas is a chordoma found? We're looking for the anatomical predilection of this very rare, slow-growing malignant bone tumor. Is it A, the thoracic region, B, the lumbar region, C, the cervical region, D, the sacrococcygeal region, or E, the bladder? The correct answer is D, the sacrococcygeal region. You see, chordomas originate from remnants of the primitive embryonic notochord. Because of this, they are anatomically concentrated right at the poles of the axial skeleton, making the sacrococcygeal region the absolute most common site for sure. And let's lock in one final histological pearl, phyzoliferous cells. These are epithelioid cells arranged in distinct chords, showing this crazy multifaculated bubbly cytoplasm. It's the pathognomonic histological feature of chordomas. Now, because these large pelvic masses require radical and block surgical excision right next to the pelvic plexus, it leaves us with a provocative final thought for this explainer. How do surgical teams best weigh the absolute necessity of complete tumor removal against the massive quality of life impacts of the complex pelvic reconstructions, colostomies, and urinary diversions that almost inevitably follow?